Sorry, by this time I should have learned to do that. Certainly, I'm very happy to be here with you and talking about vaccines this morning. As Dr. Orange-team mentioned, we have 3 vaccines approved for use in the United States. 2 are mRNA vaccines made by Pfizer and Moderna, and 1 is an adenoviral vectored vaccine produced by Johnson & Johnson. As Dr. Orange-team mentioned, they are all directed to the spike protein that is critical in the actual anchoring of the virus to the host cell and in the initiation of infection. All 3 of these vaccines were initially evaluated in very large trials, enrolling over 30,000 participants. All 3 were shown to be very effective in preventing disease caused by laboratory-confirmed SARS Co V2 virus. Although the vaccines were shown to cause local pain and swelling and some fever and fatigue in many of the vaccinees, very few serious side effects after vaccination were detected in these large trials. Based on these reassuring safety and efficacy data, the 3 vaccines were given EUA approval and the ACIP issued guidelines for use. They were universally recommended for all adults, no preference was given. And recently, as Dr. Orange-team mentioned, the Pfizer vaccine has been granted a full license by the FDA. And it is anticipated that the 2 other vaccines will apply and will receive that in the future. As time has gone on, millions of doses of vaccines have been given, and they have been continued to be highly effective in preventing serious disease and hospitalization due to SARS Co V2. The local side effects noted in the early studies have been confirmed in larger populations who have received the vaccine. In addition, more uncommon side effects have been noted in a few vaccine recipients as more individuals have been vaccinated. How have these uncommon adverse events been detected? How have we carefully assessed vaccine safety? Well, first, the CDC implemented an app on cell phones to allow you to monitor adverse events after vaccination in the COVID vaccine recipients. This system is called vSafe, and individuals report adverse events to this vSafe system. And those adverse events that are severe, individuals are contacted to determine the nature and the extent of these reactions. Second, both providers and vaccine recipients are encouraged to report adverse events to the Vaccine Adverse Event Reporting System, or VAERS. These reports are meticulously reviewed on a daily basis, and patterns of adverse events are carefully sought. Third, large medical care groups assess vaccine safety for their computerized databases with their links to immunization and medical care visits. This system, called the Vaccine Safety Datalink, or VSD, more precisely predicts whether vaccine adverse events are occurring in those recipients and whether they are more common than would be seen, and whether signals of adverse events are detected. Finally, the Clinical Immunization Safety Assessment Program, which I am a part, is a consortium of CDC vaccine experts and vaccine scientists and medical specialists from 7 academic medical centers who are unavailable on a 24/7 basis to address questions that providers have about adverse events and to try and determine whether those adverse events are related to the vaccine or other ongoing conditions, and what to do about subsequent vaccination efforts. A daily call has been held every day, including the weekends, since the start of vaccinations to be responsive to providers. Some rare events have been detected and confirmed in these systems. They are indeed rare, but they include anaphylaxis after the mRNA vaccines, Guillain-Barré after adenoviral vaccines, thrombosis after J&J, and myocarditis after mRNA vaccines. But these are indeed rare, a few in a million vaccine recipients. All are very uncommon and far fewer in number than the complications seen with COVID infection. Finally, as the Delta variant has begun, the overwhelming variant has infected patients, with over 90% of the infected patients in the United States being infected by the Delta variant. We have begun to see the effectiveness of the vaccine for the prevention of COVID infections with the Delta variant to be waning. And in fact, discussions are ongoing about the need of booster doses. The impact of this waning immunity, coupled with the more highly contagious Delta variant, as Dr. Orenstein has so clearly outlined, has reduced the ability of the vaccine to prevent infections. However, the ability of these vaccines to prevent severe complications such as hospitalization, serious disease, and death remains very, very high. Recent CDC data from New York and California have reaffirmed the protection against serious disease, including hospitalization and deaths, persist at a very high level. The vaccines are working extremely well to prevent serious disease. They need to be more widely implemented. Thank you very much for this opportunity to speak with you.
Thank you, Dr. Edwards. We will now take questions. To ask a question, click the Raise My Hand button at the bottom of your screen. For those joining by phone, select *9 and we will call on you in the same manner. First up this morning is Andrew from Stat News. Andrew, please unmute your line to ask your question.
Hi, thanks for doing this and taking my question. I was just hoping you could discuss maybe, Dr. Edwards, you were talking about how Delta is causing I guess vaccines are less effective at preventing infection. I was just hoping you could talk a little bit more about why, just because it seems like there's a couple variables at play here and like how you go about teasing that out, because it seems like there could be waning antibody levels in like the nose and throat, or just how good Delta is at replicating once it gets into cells, or just also seems like our average daily risk of exposure has gone up with no more mitigation efforts, basically. So like, how do you figure that out?
That's a very complicated question and an important question. I think that meticulous measuring of antibody levels in the clinical trials, that in fact I'm part of Moderna trial, and I'm going to get my blood drawn tomorrow now, many months after the vaccination. So measuring the levels of antibody as time goes on what they and their decline. The CDC has a number of systems that are looking at waning infection protection, such as those that have been. And I think being able to measure both of those will be helpful, but in many ways it will be difficult to dissect the effects of each of those variables on the outbreak for sure.
Dr. Orenstein, anything to add?
I would agree. There are systems. And I think we need to recognize there's a recent study that the vaccine effectiveness against the Delta variant may be 66% in healthcare workers against infection. But that's a lot better than 0%, and that we are still benefiting even against less severe, and we are particularly benefiting when we're vaccinated against severe disease. And this not only protects the individual, but protects family, protects other contacts, and protects us as a community with regard to spread, as well as taxing our overtaxing our healthcare facilities.
Dr. Orenstein's point about protecting other individuals is really important as children go back to school. And as we know, children over 12 years of age are eligible and should be vaccinated, but in those less than 11, they cannot at this point be vaccinated. But if indeed we surround them or cocoon them with adults that are all vaccinated, that is really important in protecting our children.
Next up is Jeannie from Bloomberg. Jeannie, please unmute your line to ask your question.
Hi, thank you so much for doing this and for taking my question. I hear sort of anecdotally a lot of folks who are hesitant about vaccines, looking at these sort of individual breakthrough cases and looking at that as a signal that the vaccines are not working. And I know, Dr. Edwards, you touched on this in your opening remarks, but I was hoping you could sort of respond to those folks and what would you say to people who say that? So, thank you.
Well, I think that just as Walt mentioned, we have to look at outcomes, and I think that for vaccine studies, there are always many different outcomes, and certainly we have a clear signal that there has been no erosion in the prevention against severe disease and death and hospitalizations. Just this morning on the news, I heard people saying that an intensive care doctor, every single person on ventilators in his unit were unvaccinated individuals. So I think we cannot lose the forest for the trees. And we do know that vaccines are highly effective against infection in terms of 60%, as Dr. Orenstein said from the latest CDC healthcare worker. We wish it was 100%, but 60% is certainly quite adequate. So I think that as we go on, whether we'll need boosters, whether we'll need boosters of variant strange, and certainly all the pharmaceutical companies are making those mRNA vaccines or our adenoviral vaccines with the variants. So that may be a way that we will be able to go forward. The other thing that I think is really important, and a point that Dr. Orenstein made, is that the more that we allow this virus to promiscuously replicate, the more potential that it has to make new variants. So we need to reduce the amount of transmission of the virus in the population so it has less opportunity to mutate.
And if I can add to that, I completely agree. There's a recent publication in the journal called Health Affairs from a group at Indiana University. And what they estimated is vaccinations may have averted up to now about 140,000 deaths. So that's with the efforts we have made already. And they estimate that the value economically is somewhere between $625 billion to $1.4 trillion. So even vaccines that are not 99 to 100% effective can have some major benefits to all of us. And again, for those of us who are vaccinated, it's important for us to try and convince our friends, our family, our relatives to also get vaccinated as a way of protecting them and also protecting us if we happen to be the small percentage of people not protected by vaccination.
Next is an emailed question asking the experts to speculate, are we headed down a path where we will likely be getting a COVID vaccine every year?
It's a hard question to address. I think that we'll have to see whether that is the case, whether it evolves. If we had higher numbers of individuals that are protected and vaccinated, we may find that would not be necessary. I think that we do have an example where we have a respiratory virus that does evolve, and we do need to have yearly vaccinations with a different strain, and that's influenza. But whether this will ultimately be the case, I think it's unclear. It may be that an additional booster dose of the vaccine, if we have less circulating viruses, will do us a longer time. So I think it's really hard to know and look in the tea leaves to project.
I completely agree. I think the issue is we need to have systems in place to continue to monitor things and see if future SARS Co V2 viruses escape immunity induced by the current vaccines. And again, we'll need to look at whether there's an escape issue and also the need for, is there significant waning immunity that requires frequent boosters? We don't know that, and we'll have to look. This is a new virus, and we need to be prepared for that. But at the moment, we do not have information that would suggest that is necessary.
Next is Bara from the Association of Healthcare Journalists. Bara, please unmute your line to ask your question.
Hi, thanks so much for holding this briefing. My question, actually, you just mentioned flu. The possibility is that there's going to be booster shots beginning in September. This is usually the time where we start the annual drive to get people vaccinated against the flu. Last year, we were talking a lot about a twindemic. Are you concerned about that? What do you think this is going to do in terms of what impact it will have on flu? And then the other question would be about the booster shot question itself. The Biden administration has said 8 months after your second shot. Pfizer is requesting 6 months, apparently, when it filed with the FDA. So what do you think is the appropriate timing? Thank you.
So let me start off, and then I think Walt's experience with the whole system of recommendations, I think with ACIP would allow him to address the second question very adeptly. I have been working and studying influenza for 40 years, and I started out with black hair. So look at me now. Influenza is a pathogen that is impossible to predict. Certainly we didn't see it last year, but whether it will be coming roaring back, I have no idea. I think that certainly RSV has come roaring back, and so I don't know. I think we all should be prepared for influenza by administration of the vaccine, and I think that the CISA group, of which I'm a part, and although not participated in the study, is doing a study looking at the concomitant administration of COVID vaccines with flu vaccines to assure that they work and as well. And those studies will be starting relatively soon. So I think that people need to be given vaccinations for both influenza and for COVID. I think that at this point, if it's necessary for them to be given concomitantly, we have no data to suggest that would be problematic. So I'm going to turn it over now to Walt, and he can begin to address some of the questions about the booster doses.
Okay, great. I think one of the things I'd like to reinforce is that with influenza, we make an immune response to a part of the virus that can change. And hence, the virus is smart enough to change and evade the prior induced immunity. With measles, it can change, but we make our immune response against the constant part that the virus needs. And so we don't have to worry about measles escaping. What we don't know yet with COVID is what will happen with regard to changes in the virus. We know it's happening. Obviously, we're seeing these variants of concern, and whether the immune response will cover them adequately or not. The issue on the boosters is the White House briefing said pending FDA and ACIP approval. The Advisory Committee on Immunization Practices, which I'm most familiar with, consists of many experts from a variety of fields, from academia, clinical medicine, from epidemiology, from public health, et cetera. And they will be meeting August 30th and 31st and will review the information and decide whether they would recommend we get boosters or not, and if so, when. And the issue of whether, if we need boosters, how often we'll need them, again, we'll only know with time and following up what happens.
Next is Damien from Medscape. Damien, please unmute your line to ask your question.
Hi, I'd like to know just a quick question about vaccine hesitancy. There seems to be a group between those that are for and against vaccines, and it's a group of people who are hesitating because they have health concerns or their fear of needles or for other reasons. And I'd like to know if you think the full approval of the vaccines will help to move the needle for this group and encourage them to get vaccinated.
Well, certainly the reason that people are hesitant about receiving vaccines are many. And I think that one of the important points that we need to, for people need to understand is that their specific questions, can be addressed. So they need to ask their healthcare providers about the specific questions or issues that they have. And if their providers are not able to answer that, then there are, 24/7 lines that are available for providers to provide assistance. So the questions indeed need to be addressed. I think that my understanding is that and talking to people, I think that the full licensure of the mRNA vaccine from Pfizer is reassuring. I think it also is going to be a reason that mandates can be implemented. Certainly, we had a big session yesterday at Vanderbilt where I work, and vaccines will be mandated there for all of the employees. They already have been mandated for all the leadership, and they've received them. So I think this is another important point that the actual licensure has been able to put forward.
And I would agree with that. I think that the people who are hesitant are not a homogeneous group. They're heterogeneous. And they're people who are very, very strongly against getting vaccinated. I don't think they will be impacted that much. But there is a substantial proportion that has had a wait and see attitude. And I'm hoping that they will be more willing to get vaccinated now that this is helpful. I think the one thing that we can all agree upon is vaccines don't save lives. A vaccine dose that remains in the vial is 0% effective. Vaccinations save lives. And we've got to get that point across that these vaccines are safe and effective and their benefits far outweigh their risks.
Next is Jeanette from Healthcare Innovation. Jeanette, please unmute your line to ask your question.
Hi, thanks so much for doing this today. Piggybacking off the last question, do you endorse vaccines for hospital workers?
Absolutely. I think that hospital workers can be a source of contagion to their patients, and so I think that vaccines should be given to all hospital workers. They should have already received them. I would hope that, and I think that certainly I endorse them, and all my family members and my grandchildren are all vaccinated, and I am strongly a proponent of vaccination of everyone, barring a medical or contraindication.
And I would agree with that as well. I think mandates are also something to consider in that group because, again, vaccinating healthcare workers is not only good for them, as Dr. Edwards said, it's good for the patient population, their families as well. There's a lot of confusion on the mandate issue. We don't allow drunk driving, not just to prevent the driver from getting injured, but others. And so we need to remember that there are not only individual benefits from vaccination, but community benefits as well. And that's why we have school mandates for many of the childhood vaccines, is to protect the vaccinee as well as to protect the rest of the community.
And IDSA officially supports vaccination requirements. And in fact, we are requiring our own staff to be vaccinated against COVID-19. Next is Marie from Infectious Disease Special Edition. Marie, please unmute your line.
Hi, thank you for taking my call. Well, you did a really nice job of explaining how the vaccine works with the immune system. But to some vaccine hesitant people, mRNA just sounds so scary. And there are many false rumors about the vaccine affecting human DNA or fertility. Can you talk a little bit more about mRNA and the human system?
Sure. Thank you very much, Marie. First of all, the mRNA doesn't enter the nucleus where the DNA is, where you would get concerned about, or potentially concerned about, alteration of the genetics. It stays in the outside of the nucleus called the cytoplasm and doesn't last that long. It gets destroyed. And so the data do not show any problems with fertility, And it's not, these are the first widely used mRNA vaccines, but efforts to work on mRNA vaccines have been going on for years and years and years. And the effectiveness is very clear from the studies. The safety is very clear from the studies. And certainly, I was very pleasantly surprised when the initial vaccine efficacies were 94 to 95%. I was anticipating a substantially lower efficacy. So these have been wonderful, and they really open up the potential for developing other vaccines against other infectious agents using this technology. So I think I'm very impressed with what they've done and the safety of the vaccines as well as the efficacy.
I think that just to echo exactly what Walt has said, I think also we have a lot of data about the use of the vaccines in pregnant women that have demonstrated very clearly that the vaccines are safe for the pregnant women. There are no associated increase in pregnancy complications or no increase in adverse events associated with the babies. And only 25% of pregnant women are being vaccinated. And I talked to obstetricians yesterday throughout the country, and there are a lot of pregnant women that are very sick with COVID who are unimmunized. So I think that's another really important group that need to have their questions addressed, and the very, very remarkable and impressive safety data for mother and baby reiterated as well.
A question from Louise at APHA Public Health Newswire. We know the benefits of kids going back to in-person schooling. Is now also the time for workers to be going back into the office?
Well, I think that it depends a little bit on whether you can productively work at home. And I guess if you would ask my husband whether I could productively work at home, he'd probably say I'm more productively working than I've ever worked in my life because I'm working all the time at home. So I think it's a bit of a function of how well you can do your job. It's obviously very hard to be an intensive care nurse from your couch. So I think that we should be cautious and we should be appropriate, but if you can do your work at home and you can do it productively, I don't see any reason that we need to rush back to the office.
And I would agree with that. I think that, and certainly the CDC, even for vaccinees in indoor situations, the crowd has recommended masking.
That is the last question we have time for this morning. For more information on the Infectious Diseases Society of America or to visit our COVID-19 Real-Time Learning Network, please visit idsociety.org. Thank you for joining us today.
Reunite with others. Find the walls. Climb the walls. Every fucking day. Find the walls, climb the walls, every fucking day.